So Dr. Burr sort of already introduced herself if y'all been listening.
Hey.
But she is our state's chapter new oral health champion. And I will throw it over to her right now to get us started.
Hey, everybody. So yes, as Katie said, I'm Natalie Burr. I'm a pediatrician at Little Rock Pediatric Clinic here in Little Rock, Arkansas, and I'm the new oral health champion for our Arkansas AAP chapter. Today, I'm excited to introduce Dr. Melinda Clark. She's a professor of pediatrics at Albany Medical Center. She's also an expert in children's oral health. Just some background on her. She got her bachelor's of science at LSU in Baton Rouge. Her doctorate at Albany Medical College, did her peds residency at Albany Medical Center. She's been the recipient of numerous awards and honors. Some of the ones I picked out were the 2014 Oral Health Service Award from the AAP and the 2019 AAP National Special Achievement Award for distinguished service and dedication to mission and goals of the Academy. She's also a member of the U.S. National Oral Health Alliance and the National Interprofessional Initiative on Oral Health. And so I'm so excited that we're able to hear from her. I know that I'm going to learn a lot that will hopefully help me in my role, but hopefully we can all learn some as general pediatricians. So thank you so much, Dr. Clark, for being here.
Thank you, Natalie, for that kind introduction. So I appreciate everyone having the stamina to get through the last lecture of the day, right? It's never an envious position after lunch and at the end of the day, but I hope this material is both information and helpful. I included a lot of slides here that we're not going to have a ton of time just because time is limited to review, but I left there because I know you have access to them subsequently. Some of them are resources, people that you can connect with, or additional places you can get CE for yourself or for your staff or MOC. So please review these slides at your leisure after we're done here today. So we're going to start, of course, with our learning objectives, and you can read faster than I can speak, but the focus of our time today is going to be really on that interplay between oral and systemic health. We're going to talk about caries disease process in detail and focus on fluoride. Of course, we're going to look at evidence-based practices and what are the national guidelines. I have no money and therefore I have no financial relationships. I have nothing to disclose. I'm not going to be talking about anything unapproved today. So why oral health? This movement began in earnest in 2000 with the first Surgeon General's report. And this is a sentinel report, much like the tobacco report, talking that oral disease is the most common unmet health need across all populations. Of all populations, healthy people, those with special healthcare needs, the young, the old, most common unmet health need. It is a silent epidemic, meaning that affects those with the least voice in our society. So least likely to vote are the young, the old, minority populations, and those of low socioeconomic strata. There are significant connections between oral health and systemic health. We know there are ongoing issues with access to dental care, high costs, limited resources. And the irony of the whole thing is that oral diseases by and large are preventable. We know what to do. We just don't invest in it from a systemic perspective heavily enough to prevent most oral disease. These are some of the connections, some of the publications, and this is both in the medical and the lay literature since 2000, talking about the connections between oral health and systemic health. Here's a list by bullet point. We don't have time today to review all of this literature, but if you picked apart the relationship between periodontal disease and diabetes, that's where the cost savings is. If you look at the interplay between preterm birth and poor oral health in pregnant women, there's health savings or health improvement possibilities in those domains. We know, of course, that HPV is a oral cancer causing virus. So there's lots of connections between oral and systemic health that have been ignored, largely because dentistry and medicine have grown up as two separate or largely separate professions with very little discussion in our silos about how to keep the other people's patients healthy. So the big picture of the 2000 report, Dr. David Satcher says that you're not healthy without a healthy mouth. And that's going to be our resounding theme for the next 30 or so minutes. You're not healthy unless your mouth is healthy. Those with oral disease have disease. The call to action following that Surgeon General's report has been myriad. So HRSA published reports, the Institute of Medicine published reports, all saying that all of us, any care provider, can and should be contributing to oral health. So we may contribute in different ways, but if we consider ourselves a healthcare provider, we should be doing something. We own a piece of oral health. My favorite quote is, "Dentistry is for dentists, but oral health is all of our responsibility." We went to medical school because we didn't want to go to dental school. Maybe we wanted to do both, but that's craziness. So we went to medical school and we decided to do the rest of the body. But oral health is within the domain of medical professionals. Also, I made that cute little kid at the bottom. So kudos to me, right? So what is oral health? How do we define it? And lots of people think about oral health as the absence of disease. That's a pretty narrow window of viewing things, but it does cover dental caries, which we're going to focus on today, periodontal disease or periodontal health. It is also how your mouth and teeth develop, whether or not you need orthodontia, trauma to teeth and mouth. It is absence of disease, but it is the promotion of health that we are focusing on. And we know, unfortunately, that in almost all health domains, underserved populations, minority populations, those of low socioeconomic strata, those with less English equivalency skills, have higher barriers to care and higher rates of disease. Less able to access care, the disease rates are higher, and the cycle continues. So those are some things that are listed there. You could go and add certainly more things to this list. It's not comprehensive. We could talk about those of LGBTQ community, of different ages and stages of life. So in oral health, these 6, which is your cultural group, your socioeconomic status, your geographic location, especially if you're rural or very urban, your age, your mental and social health, and then if there's a presence of a disability. Those are the ones that keep coming up study after study. If you fall into one or multiple of these buckets, it's additive in terms of less likely to be able to access appropriate care. So Susan Fisher Owens produced this in 2007, and it's like any other diagram of Venn in nature, looking at the center being oral health. And there are influences at the child level, myriad influences at the family level, and those at the community level. We may, as healthcare providers, not be able to affect all of these domains on an individual N of 1. But certainly as pediatricians, we do advocacy, we do policy and publications, we write letters to legislatures on the behalf of children. So we can influence community, family, and the child level influence. And we're going to focus a lot today on the child level influence because those are levers that are fairly easy to press in the office on a day-to-day basis. Talked a little bit about those barriers in terms of buckets of domains that are barriers, but these are a little bit more smaller level, more micro level. So financial, if you don't have dental insurance, it's very hard to access care, or if you have Medicaid or Medicaid managed care in many states, it's much harder to access dental insurance, especially dental insurance and dental care, especially if you are young or very old. We know there are issues with transportation, with work time leave. We know that there are many myths that keep propagating about safety of care or not safety of care, or baby teeth matter or baby teeth don't. You know, hint, baby teeth do matter because your single biggest risk factor for adult dental disease is dental disease in your baby teeth. We know there are issues to access to care. One is dental insurance. We're going to talk about that in the next slide. The Affordable Care Act helped a fair bit, especially the states that did Medicaid expansion packs, but it is not sufficient to guarantee care for children, especially young children under the age of 4 and those with special health needs, because there's an insufficient number of dentists to see all of the children, such that over 20% or so of kids about the age of 4 never actually receive any dental care. It's improving. I don't want to say that, all doomsday. Things are getting a little bit better since 2006 to 2016. So that's one decade, and the graphs continued at about the same rate. But if you look at the disparity between the orange kids, these are kids with Medicaid or CHIP, and the kids with blue, those are kids with private dental insurance. So we started at about 60% for private paying kids, and we've crept up to 67. In a decade, a percent, not even a year, is progress, but not overwhelming amount of progress. And we made more improvements with the Affordable Care Act from 2006 to 2016, but it's still half of the kids are not getting dental care any individual year that we measure this. And this is dental visits for children. So they're simply not going to the dentist and getting care. One of the reasons is there's not enough dentists or dental health professionals, which include dental hygienists, dental assistants, depending on where you live and scope of practice in your state. About the population of the West Coast, if you add it all up, people live in America in dental health professional shortages. So if you have insurance and no dental health professional, that's of dubious utility to you as an individual. This is a systems issue that we need to correct if we really want to take this issue seriously. It also, to me, invokes the original quote, which is all providers can and should. I do these slides, 50% of kids aren't in, 45 million kids aren't going to get care. Why? Because they need to get this care somewhere. In this case, that somebody is you, that somebody is me. Where do kids go when they have pain, or adults go when they have pain? Well, they go to the ER. Pain is the end stage of dental disease. By the time you get to pain, typically the tooth's dead, we're never going to recover it. But they end up in the dental, instead of the dental chair, they end up in an emergency room. And in the emergency room, there's not a whole lot that can be done in terms of prevention. So they usually leave the emergency room with antibiotics or pain medications. So antibiotic overuse is not helping that chronic healthcare problem. And I would argue that pain prescriptions, especially in the terms of opioids, is not helping that epidemic in our country. Opioid use at younger age exposure is associated with opioid dependency at later ages. So again, of questionable utility if we wait for kids to be in pain or even young adults to be in pain. We are then doing additional actions that cause harm instead of good. So what we're thinking about, or what I hope we're thinking about by the end of this lecture today, is moving us out of that secondary prevention, repair, and rehab cycle back into the primary prevention cycle. Those of us who do Gen Peds, and I'm a general pediatrician in a tertiary care medical center, we think all day long about anticipatory guidance, about primary prevention, about suppression of disease. Who can we screen and what can we do in terms to keep them healthy? That's the whole idea behind immunizations and lead screening. Primary prevention, stay in the big wheel, the kid doesn't get a disease, or if so, we keep it at a suppressed level. For a half of a century, we've been waiting for people to get cavities. We've been sending them out to the dentist where they repair and rehab. We're trying to drill and fill our way out of a chronic disease. Surprisingly, it doesn't work very well, she says sarcastically. And so what we're thinking about is, instead of waiting and repair and rehabbing, and ultimately they're going to go into the tertiary prevention cycle where they have significant disease, and now we're drilling and filling and we have brain abscesses and other things. We're going to think about how we can move this into the anticipatory guidance, primary prevention, into disease suppression that we all know and love. Which brings me to why us? If I wanted to be a dentist, I'd have gone to dental school. I hear that. But we did go to medical school because we wanted to take care of children. And dental disease is the most common unmet need any of your kids are going to have, statistically speaking. So why us? One, it's common and it's not going anywhere. Two, we have access, especially to little kids. Statistically speaking, they don't go to the dentist. You already saw that slide. So where do they go? They come and they see the pediatrician. On average, 13 times in the first 3 years of life. That's 13 potential opportunities to do something. Anything's better than nothing. You and I are all familiar with risk-based care. We arguably have some expertise in education and counseling. These are families that we know, we have relationships with them. So speaking about healthy eating and healthy drinking is bread and butter for us. This is just healthy eating and drinking as it relates to your oral health. And also, hey, brush your teeth. A little bit of add on, a lot of bit of game. And you and I, as general pediatricians or not general pediatricians, care about the overall health of kids, not just one piece of the care. And one of the reasons we're in this particular oral health boat is that we've been ignoring something that wasn't ours for a very long period of time. So I'm going to take a step back and I'm going to talk about what is it that I'm talking about. So I'm talking today largely about dental caries. And dental caries is the disease, the process that causes cavities. The cavity is the hole in the tooth. Let's say it one more time. Caries is a process that results in a cavity. That's the cave or the hole in the tooth. So we talk about cavities as an endpoint, but caries is a process, a multi-stage process that results in a cavity. Because there's stages, some of them asymptomatic, we have opportunities to intervene anywhere along the rate of that process. As I said, incredibly common, half of kids in elementary school, 75% or so of kids in high school, and 85% of adults have the caries process that has resulted in cavity. It's the most common chronic disease of childhood, hands down, 5 times more common than asthma, 7 times more common than allergic rhinitis. I talk about the A's, atopic dermatitis, asthma, and allergy all day long in my office. From a prevalence perspective, I should be talking about caries. Here's NHANES data. You can see there that you have the groups. The big blue group is 2 to 19, so all of them. The little kids, of course, have less disease because they've had less teeth for less years. Rates continue to go up as kids get older. And the really concerning bar is on the right there, where 13% of kids have untreated disease. They just have disease and we don't do anything about it. Early childhood caries is that disease process, but in little kids. The rest of this talk, I'm solely focusing on littles, 0 to age 5. And I'm focusing on that because 1, it gives us something to chew on. And 2, this is the domain or the age group where you and I can make the greatest intervention, the greatest amount of gains. And there's 2 reasons for that. 1, if you treat and prevent early, you have sustained effects for life. So that's important to remember. And the second reason is that children above the age of 5, statistically speaking, can access dental care. It's the little kids that are in trouble from access, and it's the interventions done earlier that make a bigger difference. So early childhood caries is caries, process that causes cavities in teeth of little kids under the age of 5. We see this disease process all the time. Front center teeth, they rot out of their head in the order of weeks and sometimes months. Parents say that the kids' teeth erupted looking like this. They in fact probably did not. That would be very rare, and they would have some other dentagenesis imperfecta. But they rot very quickly, and it's those front center teeth because it's the upper center teeth that are not protected by saliva, and saliva is your great neutralizer of the acids that cause tooth decay. Caries in older people, cavities in teenagers and adults, we tend to get in the chewing surfaces of our molars, our deep grooves, and between the teeth because we don't floss well. Little kids get front and center disease. And then in older people, when we have harder, more resistant enamel, we don't see that same disease process. The great news for pediatricians is the front center teeth are actually fairly visible. So we can see this disease, even if we can't see anything else. We don't have fancy x-ray machines. We don't have mirrors. We don't have all day long to scale in plane. We can still see rotten teeth in the center if we're looking. So early childhood caries, again, that same disease, but 5 and under, 25% of all kids, 30 to 50% of poor children. And in some poor children of Latino or Native American descent, very high rate, 70, 75%. So this is written the other way. These are kids who reach the age 5 without a cavity. In Native American populations, especially on reservations, only 23% get to age 5 without disease. So 77% of these kids have disease. And this is my favorite quote. How can we live with those numbers? 80% of all oral health disease occurs in 20% of the kids, or maybe 25% of the kids. How can we live with that and say we're doing everything that we can? So if we could get to those and intervene on those 25% of those kids, identify them and make a significant intervention, this problem would vanish or at least fade into the background. So what causes caries? Well, you have to have 4 things, right? You obviously have to have teeth. You have to have bacteria. This is actually caused by the acids of bacteria. You have to have a fermentable carbohydrate, and you have to have the tincture of time. So sometimes it's very accelerated, weeks and months. Sometimes it's a slow process over years. But these are all necessary components. The bacteria. So we talk a lot about strep mutans because it's a great virulence predictor. But there are hundreds of bacteria on the surface of the teeth involved in the pathogenesis of caries. Strep mutans is a good reflector of disease. So in studies, strep mutans, strep mutans, strep mutans, and it's a good reflector of disease. So that's fine. It tells us what we need to know. If you have high strep mutans rates or virulent strep mutans, you're probably going to have caries. But there are many other bacteria involved. Importantly, that's vertically transmitted from your primary caregiver, which in our society is usually mothers. You have to have sugar. How much sugar you eat matters. How frequently you eat it matters more than how much you eat it. I'm going to say that again correctly. How frequently you eat or drink the sugar is more important than how much you eat. It matters for your waistline and your diabetes risk how much you eat, for sure. But the bacteria on the surface of your teeth are micron sized. And so they eat micron amounts worth of sugar. Therefore, it's how frequently you're dropping the juice with the sippy cup or the bottle at night that is really the risk for enamel decay or caries. Here's your reason. Enamel, surface of your teeth, the white stuff, just like your bone, remineralizes and demineralizes 24 hours a day, 7 days a week, it turns over. Every time you eat, that's a red arrow at the top of the graph there. The bacteria that live on the surface of your teeth, right along your gum line, metabolize every carbohydrate that you eat, some of them, and they create acid as a byproduct. They secrete acid, drop it on the surface of the tooth, and the pH of the surface of your tooth plummets. So 7 is nice and neutral. Your tooth is happy if its pH is 7. Anytime it drops before the magic red line there of 5.5, then your tooth is not happy. It enters a demineralization or a leaching out of calcium and phosphate. Anytime you live under that line of red line of 5.5, your tooth is decaying. Anytime you live above the 5.5, your tooth is healing or remineralizing. The more time in a 24-hour period you live under that 5.5 line, the more likely you are to have cavities. It's really as simple as frequency and time under the line, and of course your own enamel health, like how resistant your teeth are. What makes it go back up from that 4 or the 3.5 to above 5.5? Saliva. Saliva buffers acid on the surface of your teeth and in your mouth, and it also provides calcium and phosphate for remineralization, and also fluoride to incorporate. And fluoride in your enamel, fluorohydroxyapatite, is stronger and more resistant to decay than hydroxyapatite. Therefore, it's less likely to break down and it remineralizes at a more rapid rate. This is the reason why we tell kids 3 meals a day and a snack, no juice. This curve, in large part. As I said, caries is a progression from healthy teeth on the upper left there to abscessed teeth and decayed teeth on the bottom right. The second of those pictures, which is white spot lesions, this is what I want us as general pediatricians to start being able to identify, or more reliably. Right along the gum line there is a white spot lesion. It looks like a little half moon. That is the early stage of caries. That will, if nothing else changes, become a cavity or a hole in the tooth. And if nothing else changes, the bacteria will crawl right through and cause an abscess in the dental alveolar ridge, which we all see routinely in our offices. Important to note that yellow arrow. If you have only white spot lesions, if you make interventions, fluoride, brushing, flossing, changing your dietary habits, you can return to a completely normal tooth surface. So white spot lesions, though they are the process of caries, are early enough, if you identify them and make a significant intervention, it can be reversed to the state of normal or healthy. Hence, we need people to recognize them and make an intervention. See, these are our stages. Here's early childhood caries stages. Upper left is white spot lesions. Upper right is dentine caries, where now the bacteria have crawled through the surface of the teeth, eaten away the enamel. You cannot regrow your enamel. So once it's gone and you have an actual cavity, then you can't regrow it. You can only drill and fill it. So that dentine is now those brown spots close to the gum line. They started out pale yellow and they get stained with pigments of food. On the bottom left, there are the pulpitis. This is this first stage of all of this that the child begins to feel pain. Before that, if you're just going through enamel has no nerve. It's not till you get to the root that the bacteria get down there and cause inflammation and pus, that the nerve begins to be affected, causing pulpitis, inflammation, triggering pain. If you've ever had pulpitis and you ever had a root canal, it is not a pleasant experience. And it's particularly unpleasant experience in a 2 or a 3-year-old who now has to be sedated in an operating room. So the process what we'd like to do is identify enamel caries, reverse them. Failing that, we'd like to recognize dentine caries before they become pulpitis, because now that is a root canal to save the tooth. Once you get to D, an abscess, that pulp of that tooth is eaten away. It's dead. The nerve's gone. The blood vessels are gone. There's nothing left. That tooth is either going to fall out on its own or it's going to have to be extracted. There is no other option. That tooth is dead. It turns that black or brown color as happens with trauma. We'd like to not see that near so much as we do in primary care. So some risk factors I reviewed. The only one I want to bring to your attention besides the things that I've already said is fluoride is protective, and the presence of anything else that adds acid to the mouth or interferes with saliva is a risk. So refluxers, bulimics, those who have medications causing xerostomia, all of those are additive in terms of risk factors for caries. So we as primary care providers who do comprehensive care really need to think about whether or not we're impacting saliva or our kids also have reflux or other acidic environments. We also know that children with special health care needs are at risk for lots of things. That also includes increased risk of caries, although not all special health care needs are created equal. So trisomy 21, for example, in Frank's study was fairly close to other to age-matched peers who don't have any developmental concerns, but children with autism who have more adverse dislike of oral and of oral care and have a more challenging time at the dentist, those risks are higher. Children with CP who can't really perform oral care, that risk is higher. So what if we just sort of don't and we just leave it like it is? These are the consequences, and they're real and they're significant. Pain, chewing, nutrition, weight gain, sleep, loss of school, loss of work, and baby teeth caries equals adult caries, high fidelity. 3 times the risk of missing school and poor school performance, all other things being equal. So we're concerned about school access and care. If we fix caries, we will make an improvement in those domains also. And this is Casamigos' economic cost. At the top, of course, is death from infection or sedation. That's fortunately rare. It happens, but it's rare. But as you start going down that larger pyramid, you can see the cost of morbidity and mortality from hospital admissions, usually from infection, facial cellulitis. More than half of facial cellulitis in the US are untreated dental caries. Family association, loss of work time, and things at the bottom are missed school, treatment with over-the-counter pain medications like Tylenol, which is not a benign medication. So death is bad but rare, and the other ones are quite common and not at all rare. So how do we prevent it in the little time we have left here? Well, if I had one intervention, if every child brushed their teeth with fluoride toothpaste twice a day for 2 minutes, this problem would be better. If we all ate better, this problem would be better also. But the single biggest intervention from a population perspective is toothbrushing with fluoride toothpaste twice a day from tooth eruption. Get going on the toothpaste as soon as there's a tooth. Change our diet, delaying colonization, getting to see dental providers earlier when at all possible in your community. As I said, saliva is good, lack of saliva is bad, and then fluoride. It is a balancing act. If you have more pathological factors, then you have to have more fluoride, improved diet, and better salivary flow. Want to brush twice a day? Bedtime is the most critical because that's when saliva levels are lowest. You want to brush all the teeth, focusing right along the gum line up front. Parents should help until children can tie their own shoes or write in cursive. This is what brushing should look like, minus the part where you're kind of swishing the neck. If you have two people, that's ideal. If not, have them face a mirror and brush from behind because it feels much more natural. Healthy nutrition, this is bread and butter of pediatrics, so I won't spend much time on it, but breastfeeding is good for oral health in addition to everything else it's good for. And the juice is bad. We want to get rid of a bottle as soon as possible, and we certainly don't want to be serving juice from a bottle. Little to no juice is the way to go. Drink water. Water is good for you. Water with fluoride is even better. Healthy eating, healthy drinking, minimizing snacks, minimizing sticky foods, and certainly nothing touches your teeth after your toothbrush at night before bed that has carbohydrates in it. We know that we should be delaying colonization because if the moms have cavities, the children are more likely to have cavities because the moms are more likely to transmit caries, causing bacteria at younger ages. So getting moms care will help them and help their offspring. ACOG agrees, as does the American Academy of Pediatrics. Pregnant women should be getting care. It is healthy for them during pregnancy and will also help their child stay healthy. Don't delay. You're brushing for two. And of course, a dental home. We've been talking about establishment of dental home for, 20 or 30 years. Still, children routinely don't go to the dental home at age 1. So where do they go? The pediatricians. And of course, those with special health care needs need to be seen more often and typically by a pediatric dentist who has specialty care. Talked about xerostomia. My last and final thing in the few minutes we have left is I'm going to focus on fluoride. This is where most of the questions come. Fluoride works great. It's the closest thing we have to a magic bullet for oral diseases, for dental caries. The topical effect is by far and away the most important. I don't really care if you eat it. I care if you drop it on the surface of your teeth. It does those three things there. The enhancing remineralization is the most important. It treats those white spot lesions and reverses them to normal disease. High saliva, more fluoride, improved remineralization. Some is good, more is not better, just like table salt. Where do we get fluoride? From all of these sources. If you happen to live in a community that has water fluoridation, then we don't discuss fluoride supplementation. Otherwise, children should be written fluoride supplements if they're not drinking fluoridated water. And that's from age 6 months to age 16, our current guidelines. Everybody should use toothpaste. Those that are high risk after the age of 6 should consider mouth rinse. And you and I should be applying fluoride varnish. Questions about fluoride toothpaste? A smear. I talk about it as a grain of rice, which is something that most families can understand, a cooked grain of rice under the age of 3. And after the age of 3, a pea-sized amount. This is a green pea, not a chickpea, a garbanzo bean. Whole green pea amount. More is not better. Aquafresh is trying to sell toothpaste with that big swirl. Fluoride varnish is the last and final. Fluoride varnish is what you and I can apply in our office to prevent caries. It's been studied for decades, especially in Europe. Those studies have come in the United States. Many states looked at this from a state perspective in terms of intervention, retreat, training all primary care providers. North Carolina had it into the mouth of babes program, and they studied their results. And what did they find? They found that if you apply fluoride varnish at younger ages, 4 or more, rates of caries drop by about 20%. So if pediatricians apply fluoride varnish, rates of caries drop by 20%. And lo and behold, if you do it at younger children, 12 and 15 months of age, your reduction of caries is closer to 50%. 50% for something that affects 20 to 50% of your kids that you serve is a huge reduction. Because of this data, USPSTF in 2014 said, yeah, that's great. Children with teeth should have fluoride varnish applied in the primary care office from tooth eruption through the age of 5, so until the age of 6, grade B recommendation. That's USPSTF, national guidelines. The AAP said, yay, we agree, right? Fluoride for everybody, not just poor kids and high-risk kids, because it's safe and it's effective. It was added to the periodic schedule, so our Bible in 2015, and that also becomes gold standard, should be covered by all payers with no cost sharing to families. Fluoride varnish is a lacquer painted on the surface of the teeth. It's typically white, not yellow as in that picture. Instead of being there for 10 or 15 minutes like gels and foams of toothpaste, it releases fluoride over several days, strengthens the teeth, lowers risk of caries, slows progression of disease. More is earlier, better. Earlier is better. So we'd like to do it at 9, 12, 15, 18 months of age. Lo and behold, those are your preventive visit codes. We like to do them at younger ages because the intervention is more effective. It's very safe. You swallow a little bit, of course you do, because you're putting it in the mouth. As long as you're applying it appropriately, you're not going to cause fluorosis or any other problem. There's no anaphylactic reactions in the literature. A few kids who were allergic to it, as any other medication, had a little contact dermatitis or stomatitis. We don't apply it if there's open lesions. If they have HSV gingivostomatitis, you have bigger problems that day, and you should probably wait and apply the varnish when the child is clinically well. But open wounds, it burns, so just be careful. There's aphthous ulcers. We do it by way of knee to knee exam. Takes a minute. Provider holds the child in their lap, wearing a mask and gloves and goggles, please, in the pandemic especially. And you paint the teeth just that way in 4 little quadrants. There are videos that I provided to Katie, and hopefully she provided those links to you folks, and or she will, to learn how to apply fluoride varnish in your office. They're also available online. White spot lesions along gum line, that's where we're looking to paint. Dip, wipe, and apply. 30 seconds. This is what it looks like in the office. Everything's a mess and the kid's screaming, the parents kind of holding the kid. If they scream, then I can paint because at least the mouth is open. After the varnish, important thing in infants and toddlers, they can eat and drink right away. There are no restrictions. Just really not a lot of hot and sticky foods. Who does peanut butter and hot soup in 12-month-olds anyway? Not very many people. But try to avoid hot and sticky foods for the rest of that day and resume your brushing the following morning. For that night, leave the varnish on, resume your normal care the next day. Questions are always going to be about billing. CPT code is 99188 in all states, including Arkansas. You want to link it to an ICD-10 prophylactic fluoride administrative code, Z29.3. An AP Oral Health Home has information about billing. In Arkansas, 99188, I looked it up. You are reimbursed for fluoride varnish. Typically, they say $19.95 for children from tooth eruption until age 18. I don't know if that's Medicaid or all payers, but about $20. We make $20 or $30 by payers in New York State. Varies by payer, but a minimum of 20 and a maximum of 33, I think it is. The varnish cost about $2. So it's a minute of your time, $2 of investment, a little bit of gauze, and it's about a $19 return on investment in our state. You've had approval in your state since 2014. You are allowed to delegate to providers such as nurses in your offices. And our Dr. Burr already introduced herself. There's her email. I hope it's correct. In case folks want to contact her, she's nodding yes, want to contact her about specific questions in Arkansas. And I have my email at the end if you have questions about office integration. We want to apply it every 3 to 6 months. In general, all the national guidelines are 6 months for low-risk kids, every 3 months for high-risk kids. So you, as an individual, if you don't do primary care, you can and should still be talking about oral health in all populations to families. We can all promote nutrition and oral hygiene. We can think about those kids that are high risk and the medications that we prescribe. If you're prescribing xerostomach medications or medications with sugar in them, you've increased that child's risk. You should be talking about seeing a dental care. And if you do primary care, you certainly can and should be applying fluoride varnish, and you will be reimbursed for it. There are barriers to anything that's new or different, although I have argued here that we can and should nationally be doing this, and at least we're now being reimbursed, and it has a significant impact on disease. I hope I've made the case today that oral health matters, both to the overall health of children, to the quality of life of children, and it does save cost dollars, although we didn't talk about that much today, that we can and should be doing this because it will improve health outcomes and we will be reimbursed for it, and that it is all of our responsibility and we can. And with that, I'm going to take questions. And if there are no questions, I'll review resources, or you can do that on your own time in the 12 seconds we have left.
Thank you so much. I do think there's some questions in the chat. Let me see. First off, a comment. Your kid's very cute.
Thank you. I agree. 16 now, though, so some days he's cute.
Let's see. Oh, how to handle the toothache while waiting to be seen by a dentist as a just a general pediatrician.
Yeah, so that's a tough one. It goes back to Tylenol and ibuprofen. Unfortunately, unless you see evidence of an abscess, a dental ovary abscess, or pericoronitis, the inflammation of the flap over the tooth, which case those kids can improve with rinsing, mouth rinsing, saltwater gargles, or antibiotics if you think there's infection.
Right. Okay. And there was just a comment, we have in our less populated areas, just people that really just won't see kids that are under the age of 3. We have pediatric dentists in Central Arkansas, which is a more populated area, and then in Northwest Arkansas, which has a denser population. I guess anything that you've done in your work with dentists to try and motivate people to see younger kids?
So one of the struggles is a great question, and it's a chronic issue, right? For most states, dentists are generally trained to see patients 7 and above. So in dental school, they don't touch a child under the age of 7. There's movement to kind of lower that age, but a 7-year-old is not a 2-year-old. So several states, Massachusetts, it's one that's done this very well, in my opinion, have done cross-pollination where pediatricians go and help dentists learn to do behavioral management, and dentists come and train them and their office staff on how to do improved oral health. So if there are relationships with local folks, they might feel a little bit better if you teach them your tricks and tips on how to do behavioral management. And some of that is formalized and many of that is ad hoc and sort of done on an individual level. I have personally in my community met, reached out to, talked to, gone out for dinner with all of the local dentists. In doing so, many of them will then take my phone call and I'm like, oh, it's a 5-year-old, but they're really mature, right? Or we talk a lot about the 2-year-olds and the 3-year-old management. Pediatric dentists are universally comfortable, but in order to get with small children, but in order to get kids into them, they can't be full of healthy 1 and 2-year-olds because there's no way for them to sick kids to get in, especially on an urgent basis. So one of the things that I'd like to see in terms of movement process of systems issues is pediatricians to own more of varnish and prevention like we do every other disease. There's no other organ that automatically sees a specialist, right? If you have a brain, you don't see a neurologist. If your heart, you don't see a cardiologist. Mm-hmm. But if you have teeth, you have to see a dentist. That's it. This is the only one. So if we could own a little bit more of prevention, we could train general dentists to serve littler kids, then they could act as a gateway and reserve the pediatric dentist as subspecialists for kids who really need more serious intervention and certainly surgery.
Had another said, do we give fluoride supplements to only kids on well water or city water as well, since city water has fluoride added?
So it's a great question. It depends on your city water. So if you have city water where the fluoride is added, if you don't know, you can Google CDC's My Water's Fluoride, and you can look at state, county, and town of any county in the US that reports, which is the vast majority of them. So if you don't know, you should look it up. If they have community water fluoride, there's no reason to supplement. The only one to supplement kids that don't have access to fluoride. Well water is tricky because some wells have naturally occurring fluoride in them, and you don't know how deep they dove, right? Or they drilled to get the water of the well, and the closer you are to the Earth's crust, the more likely you are to access fluoride. So in places in India where they drill very deep because it's always a drought, they'll have 4 to 8 times the amount of recommended fluoride. So If there's well water, I recommend families have that tested, and most local counties will do well water testing for fluoride if it's not already on their well report.
Okay. And on that note, if giving an oral fluoride supplement, should you also still apply fluoride varnish?
Great question. Every child with teeth should have fluoride toothpaste. Every child with teeth should have fluoride varnish. Every child with teeth should get a supplement or drink fluoridated water.
Okay.
They are separate and independently for all kids. They don't
And then, sorry, thoughts on kids' mouthwashes?
So mouthwashes with fluoride should be reserved for children 6 and above who are considered high risk for caries. The AAP in my resources has a risk assessment tool that you can access. But if children are high risk, they've had cavities in the past and they're only 6 years of age, then you could additionally add a fluoride supplement like Actor, Infector Hector, or whatever. But fluoride supplements should only be for kids who are high risk for caries above the age of 6 because it's highly concentrated, easy to swallow. You don't want the littles anywhere near a fluoride mouth rinse.
And so is that similar for like the prescription toothpaste, like the Clean Pro and those kind of things?
Yep. Prescription toothpaste should be older children that are high risk. I typically allow the dentist to make that decision. If they're that high risk, they really should be getting dental care because they're always going to be above the age of 6 before I'm engaging in that discussion.
Okay. Let's see, I think there was one about maybe needing a CBC and chest x-ray before dental work. I'm trying to find that one. It just said, do we need any CBC or chest x-ray to clear for operative dentistry under GA? I'm not sure what GA stands for.
So I don't know the answer to that, in part because I don't work in your state, and in part because I think that's actually going to probably be a dentist or an insurance provider specific question. So like you would clear any kid for surgery, it depends on what the specialist feels that they need. And that's a conversation and interplay between the generalist and the specialist about what would be appropriate. So I don't think there are standard guidelines that every child having dental care needs to get these things. The majority of kids don't need any screening labs. But I don't know that I could speak to that in your county, your state, and your payers.
Right.
I did
And as far
hear about fluoride in bottled water, and I think that's a good question. So people who, when you drink bottled fluoride, you drink the water that came out of the ground somewhere in the world. It may or may not have fluoride in it. It just depends on whether or not that area of the Earth's crust had fluoride. So you don't know. They only have to declare it if they added fluoride. So the only ones you're certain have fluoride is if it says nursery water, that's actually fluoride added. So you don't want to use nursery water under the age of 6 months. It's fine to do so after because it would be in lieu of your tap water.
Okay. There's one here that says earliest age to floss.
As soon as the teeth touch. So in little kids who have very tight teeth, especially typically the premolars and the molars, you want to be flossing the teeth, but you only have to floss teeth that touch once a day. If the teeth don't touch, and little kids have a lot of space, typically in their front center teeth, the tooth bristles will get in between there and you don't need to floss. But any teeth that touch should be flossed.
Cool. And how many times to brush a day? I think you touched on that twice.
Twice a day. All the teeth, all the surfaces of all the teeth.
Okay. I'm not seeing any new ones. Thank you so much.
You're welcome. Do I have a minute to run through these resources?
I think so. Yeah, you're the last presenter, so absolutely.
Yay. And people can leave, right, if they got places to go. But I would like to just, maybe it'll let me go. So AP as an oral health home, go visit it. This is where you can find your section and learn more about it. This was information that was provided to me by Anna and Katie. There's a Paint a Smile program in Arkansas, and they are known for training folks in the office on site how to do fluoride varnish training. They have Smile ambassadors. This is the website. You have to scroll down to the bottom of the DOH website that's here, but they will help you through this process. If you're feeling like I'd like to do this, but I'm not sure how to get going, you could contact these folks and they do this for free. I don't know what their access is like in pandemic, but hey, it's worth the phone call. You also, of course, have a resource in terms of Dr. Burr. There are BOP and POP training programs for baby and prenatal if you want to learn more about oral health. This is Smiles for Life. Smiles for Life is an online comprehensive training program across the lifespan. There are 2 modules, one child oral health and one focused on fluoride varnish. This offers free CE to you, to nurses, to PAs, to dentists, to pharmacists, so medical assistants. So if you want your office to be trained so you can delegate, they can go here, they can get training, they can get CE credit for doing so, and the training would be done and they can print a certificate. So it's a nice place to go and visit, Smiles for Life. The AAP for fellows also offers a quality improvement program focused on oral health. So if you're thinking of doing it and you need MOC or CE credits, sign up for the EKIP. You have to gather data as you do for any quality improvement, but if you're going to do fluoride varnish anyway and you're starting out at 0, anything you do is 100% improvement, right? From a quality improvement perspective, it's easy to do a PDSA cycle from very, very low levels of 0. And it's a nice and I think easy program to work with and free if you're a fellow of the AAP. I mentioned that there's a risk assessment tool available free at the AAP. There's also an app available through Smiles for Life, same practice tool. And Qualis put out a white paper helping us with the how. So if you're thinking, I need to get going, but I'm not sure how to do it, they have resources like PowerPoints and sticky notes, who can be delegated, what piece of it in the office to help you think through flow of making a systemic change. To the office, I have resources here because you should always have resources. And then I made 2 that look the same. So thanks for bearing with me as we went along. Again, I'm happy to answer questions via email. And Dr. Burr is kind of working her way into this job. And so we're happy to support you. This is good. It's important. It's reimbursable. And it's incredibly easy once you get going in your office. My staff is always excited to teach people and to train new folks how to do this. We train our new residents in July, the first week, and they're doing it by the second week of July. So this is easy and simple to do in terms of fluoride varnish and more overall comprehensive oral health care in the office. Thank you for your time.
Thank you so much, Dr. Clark. We really appreciate you joining us. And we will, I guess, wrap up our day now. Katie, did you have anything you wanted to share at the end of the day? Okay. Thanks again, Dr. Clark. And thanks, Dr. Burr, for jumping in and facilitating and everything today.
Have a great day, guys. Thank you.
So I think the only thing, we just wanted to go over our schedule for tomorrow. You know, at 8 a.m. you can hop on and talk to the folks in the virtual vendor hall. And we will get started with presentations at 8:30 tomorrow with our transgender and LGBTQ health session. We also will have some resident poster sessions that we're really excited about, as well as physician mental health and well-being, which is incredibly important after the very tough 1.5 years we have had, and then the next however many months we have too. And then we will also get to hear from Secretary of Health, Dr. Jose Romero, on all of the COVID-19 updates in children and vaccines. Incredibly important sessions tomorrow, along with our business meeting. And so it'll be the same exact link, same exact log on. Luckily, we don't have to worry about any breakout session issues tomorrow, so that shouldn't be a problem. But if you have any questions or anything, you all have my email. And so tomorrow, all of these plenary sessions will be MOC as well. So make sure that you attend those so that you can get those MOC credits. And Anna, is there anything that you have?
I just want to tell everybody thanks. I know it's been a long afternoon. We've tried to work in lots of good breaks every hour, so we're trying to keep you guys up and moving at times. But thanks for sticking with us, and we hope you've enjoyed today. If you'll have any feedback before tomorrow, feel free. Katie and I can stick around for a few minutes, and you can feel free to share it out loud or on the chat. And we look forward to seeing you bright and shiny early in the morning.
Yeah, thanks y'all so much. This is our first conference in like 7 years, first virtual conference. So we really appreciate your support and sticking with us today if there were any technical issues or anything like that. So thanks y'all.
Appreciate everybody.